Good morning, everyone. My name is Dana Argero, and the title of my project is Improving Patient Mobility in the Critical Care Unit. Defining the problem. Prolonged bed rest and physical inactivity is a common problem in the critical care unit. It can cause neuromuscular weakness, bone demineralization, skin breakdown, pneumonia, blood clots, atelectasis, systematic inflammation, insulin resistance, and many other complications. This practice can lead to extended hospital stays and serious disabilities even after 1 year of being discharged from the hospital. There are many benefits of increased mobility. The first is it can increase levels of consciousness. It also can improve respiratory and cardiac function. It can reduce muscle weakness. There can also be improved functional independence, and it can increase psychological well-being. It also has the potential to reduce duration of mechanical ventilation. There are many barriers to patient activity and mobilization. Many still believe that bed rest is best in the presence of illness. Patients are considered too sick by the medical staff to participate in physical activity. Some medical professionals believe that dangers are too great and that it takes too much effort. Proper equipment is unavailable, such as recliners and cardiac chairs, and there is the ease of neglect. Other barriers to patient activity and mobilization include lack of planning of range of motion activities, concerns about patient falls. There's the risk of pulling out patient tubes, and many times patients are too heavily sedated for mobilization. Patient agitation can also be a barrier, and lack of staff. Interventions from the literature. Mobility strategies to increase ambulation. The first mobility strategy was a mobility protocol. This was obtained from a level 3 quasi-experimental trial from the United States. The authors were Drolet, DiGiulio, Harkis, Hendricks, Kameen, Letty, and Williams. The article was published in 2013. The title of the article was Move to Improve: The Feasibility of Using an Early Mobility Protocol to Increase Ambulation in the Intensive and Immediate Care Settings. The article was obtained from Physical Therapy. The second mobility strategy was application of a graded mobile leg press and hydraulic platform walker to increase ambulation. This was obtained from a level 4 case study from the United States. The authors were Trees, Smith, and Hawkard, and the article was published in 2013. The title of the article was Innovative Mobility Strategies for the Patient with ICU-Acquired Weakness, a Case Report. The article was obtained from Physical Therapy Journal. The next interventions were becoming a mobility champion on your unit, completing a literature search on the effects of immobility, educational in-services, and a nurse-driven mobility protocol. This information was obtained from a Level 7 expert opinion article from the United States. The author was Bell, and it was published in 2009. The title of the article was Achieving Early Mobility in Mechanically Ventilated Patients. This article was taken from the American Journal of Critical Care. The next intervention, decreasing staff reluctance in mobilizing critical care patients through evidence in research, a nurse-driven mobility protocol, and staff education, was discussed in 3 articles. The first article was a Level 1 systematic review and meta-analysis from China. The authors were Li, Peng, Zhu, Zhang, and Zai. It was published in 2013. The title of the article was Active Mobilization for Mechanically Ventilated Patients, a Systematic Review. It was obtained from the Archives of Physical Medicine and Rehabilitation. The next article was a Level 6 descriptive study from the United States, authored by Winkelman and Perryboom. The article was published in 2010. The title of the article is Staff Perceived Barriers and Facilitators. The article was obtained from Critical Care Nurse. The next article was a Level 7 expert opinion article from the United States, authored by Clemmer in 2013. The title of the article is Why the Reluctance to Meaningfully Mobilize Ventilated Patients. The answer, my friend, is blowing in the wind. The article was obtained from Critical Care Medicine Journal. The next interventions were about reducing bed rest in the critical care based on the evidence that it improves patient outcomes, and that was discussed in 2 articles. The first article was a Level 1 systematic review from the United States. The author of the article was Adler and Malone, published in 2012. The title was called Early Mobilization in the ICU, a Systematic Review. This article was published in the Cardiopulmonary Physical Therapy Journal. The next article was a Level 4 prospective observational cohort study from France. The author of the article was Borden, Barbier, Buell, Durante, Pesset, Vincent, and Gurin. The article was published in 2010. The title of the article was Feasibility of an Early Physical Activity in ICU Patients, a prospective observational one-center study. Decision. Interventions to be used to decrease the problem of immobility. A decision was made to decrease staff reluctance in the mobilization of critical care patients through nurse education on the detrimental effects of bed rest and the benefits of patient mobility. The other intervention to be used was the implementation of a nurse-driven mobility protocol. Rationale for the decision. The decision is judged to be moderately strong, very well-rounded, and based on most levels of the hierarchy of evidence. The hierarchy of evidence levels for articles included a Level 1 systematic review and meta-analysis, a Level 3 well-designed controlled trial without randomization, Level 4 well-designed case study, and a Level 6 descriptive study, and 2 Level 7 expert opinions. Another reason for the decision was bed rest is a commonly practiced for critical care patients at this North Carolina facility. Many nurses in this unit have never mobilized a ventilated patient, believing the dangers are too great and that it takes too much effort. There's also lack of nurse education on the dangers of immobility and the benefits of mobility. Implementation of intervention. The implementation of this intervention will be based on Hospital Policy RI-23. One must contact organizational learning before starting any project in this facility. One must also contact the Department of Research and Evidence-Based Practice for project approval. Upon approval, a practice mentor is assigned by the department director and assists in determining if the idea is a potential evidence-based practice project and gives further direction. Evidence-based practice projects are implemented through a process with the following steps: assess, ask, acquire, appraise, study design, IRB approval, collection of data, analyze, and disseminate. Next, the Institutional Review Board must give approval to the project. Then the Critical Care Committee gives approval to the project. Shared governance will coordinate involvement of many departments and implement the project. The Department of Pharmacy will be involved because patients will need decreased amounts of sedation to mobilize. The Respiratory Therapy Department needs to be available to assist nursing when mobilizing ventilated patients. The Physical Therapy Department will assist nursing in mobilizing critically ill patients. Nursing education will be involved, educating nurses on the dangers of immobility, the benefits of mobility, and the nurse-driven mobility protocol. Clinical technology will also be involved in this intervention due to the changes in documentation due to the use of using the nurse-driven mobility protocol. Implementation of the intervention. The first thing that will happen in this intervention is a pre-test. And remember, the focus of this project is to critical care nurses. A test will be given to the critical care nurses on the practice of mobility and current application. Following this, the intervention will include nurse education. Nurses will be educated on the detrimental effects of bed rest and the benefits of patient mobility. This will be presented through a PowerPoint presentation. Following this, the nurses will receive an introduction and the implementation of a nurse-driven protocol. This will also be presented via a PowerPoint presentation to the nursing staff. Following this, a post-test will be given. The test will be given only to critical care nurses after the intervention of nurse education and a nurse-driven mobility protocol is implemented to see if these interventions decrease staff reluctance to mobilization and increased patient mobility. Evaluation of outcome. My project uses a pre- and post-test design. Sample characteristics include gender and years of critical care nursing experience. The outcome: nurse education and implementation of a nurse-driven mobility protocol will increase patient mobility in the critical care unit, will be calculated through statistics using a paired t-test. Evaluation of outcome, paired t-test. I did not get to implement my project at my facility due to time constraints. To start and implement an evidence-based practice project at my facility would take months, and I did not have months to do that. But I would like to show you an example of how I would evaluate my outcome if I was given the opportunity to implement and complete my project at my facility. As you can see in this example, there are 20 nurses. Gender and years in critical care nursing are the sample characteristics. Mobility pre-test and mobility post-test are my dependent variables. Evaluation of outcome, paired t-test. Now, this information right here was done in the Excel data analysis pack. we're going to look at this right now, and we already know that nurse education and a nurse-driven mobility protocol, just by looking at this, if you look at the mean for the pre-test, it was only 72.65, and the post-test, the nurses scored 83.25. So we know just by looking at this that this intervention has already increased patient mobility through what the nurses have reported. Looking at this calculation, the important numbers that we're going to look at are the T-stat, and that was negative 4.4659. And we're going to look at the one tail. If you go down and look at this under P, the one tail is 0.0001324. And those are the important numbers we're going to look at in this paired t-test. Evaluation of outcome, paired t-test. The research question for this project will be, will nurse education and implementation of a nurse-driven mobility protocol increase patient mobility in the critical care unit? My null hypothesis would be nurse education and implementation of a nurse-driven mobility protocol will not increase patient mobility in the critical care unit. My research hypothesis from the researcher, which is me, is nurse education and implementation of a nurse-driven mobility protocol will increase patient mobility in the critical care unit. After that, we have to decide whether this will be one-tailed or two-tailed. It will be one-tailed based on the word increase. Increase means one tail. Level of significance, which is A, would be 0.05. That means there's a 95% chance this decision will be accurate. What was T? T was negative 4.4659. And that was under the T-stat in the previous slide that you saw. And what was P? P under one-tailed, which this is one-tailed, was 0.00134. So what we do now is we compare the level of significance A, which is 0.05, and P, which is 0.00134. And the decision would be, since 0.00134, which is one-tailed, is less than 0.05, which is A, we would reject the null hypothesis, and the decision made would be nurse education and implementation of a nurse-driven mobility protocol significantly increase patient mobility in the critical care unit. Conclusions and recommendations. My project was not implemented, as I said earlier, due to time constraints at my facility. My facility is very interested in my project, and my site facilitator would like me to present this project to the critical care manager and shared governance. My project is very applicable to nursing. It has the potential to change nurses' attitudes towards bed rest. It has the potential to promote a culture of patient mobility and produce improved patient outcomes. Positive. My project was very worth doing. It could decrease the damaging effects of immobility and give nurses new confidence in the practice of mobility. Negatives of this project. It's sad for me to say that nursing has been very lax to take constructive action in the practice of mobility with critically ill patients. Another negative was my project was not able to be implemented due to time constraints. A future project recommendation would be development of a permanent interdisciplinary team consisting of a critical care RN, nursing assistant, physical therapist, pharmacist, respiratory therapist, and a nursing education staff member. I feel that this would be very important because these people would champion mobility in the critical care unit, and they would also keep the staff consistent with the practice of mobility. Thank you so much for listening and viewing my presentation today. I've really enjoyed presenting it. This project is a passion of my heart, and I look forward to seeing each of you at graduation.